Good afternoon. My topic is the update analysis of the NEJ009 trial, which studied Gefitinib versus Gefitinib plus combination with chemotherapy. So the background, the NEJ trials of NEJ002 compared Gefitinib versus platinum-based chemotherapy, which showed improvement in PFS but no improvement in OS, with high crossover rates and 30% on Gefitinib after intensive chemotherapy. Further, NEJ005 trial, which studied the concurrent versus sequential use of the same agents of Gefitinib and combination chemotherapy containing platinum agents, which didn't show any improvement in PFS, but it showed improvement in the OS of 41 months versus 30.7 months, favoring the concurrent arm. So this study group further advanced into NEJ009 trial, which used combination of Gefitinib and chemotherapy in the concurrent setting. So before going to the NEJ009 trial, discussing the trial by Dr. Vanitha ma'am at TMH, which studied Gefitinib with combination of chemotherapy, carboplatin and pemetrexed in EGFR mutant NSCLCs, which included chemotherapy naive patients, metastatic or recurrent NSCLC patients having EGFR mutations 18, 19 and 21. An important difference here was that ECOG PS of 2 was also taken. And asymptomatic CNS mets allowed. Total trial number include participants who are 350, which were randomized to Gefitinib with combination chemotherapy versus Gefitinib alone, and primary endpoint being PFS, which was 16 months in the combination of Gefitinib plus chemotherapy versus 8 months in the Gefitinib alone group, while the overall mature results are still awaited, which was it showed in Gefitinib alone it was 17 months median OS, while the combination group the results are awaited. Going to the NEJ009 study design, it was a randomized phase 3 design. The inclusion criteria being chemotherapy naive patients of recurrent or metastatic non-squamous NSCLC having harboring EGFR mutations, exon 19 deletions and the rare mutations from age 20 to 75 years, and ECOG PS only 0 and 1. The exclusion criteria being pre-existence of T790M mutation, symptomatic brain metastasis, and concomitant serious systemic illnesses. So this was a study design in which the patients were randomized to Gefitinib 200 to 250 milligram daily alone versus Gefitinib plus pemetrexed and carboplatin chemotherapy, and the stratification was done according to gender, stage, EGFR mutation and smoking history. The primary endpoint was PFS, PFS2 and overall survival, while the secondary endpoints were objective response rates, safety and quality of life analysis. So here the radiographic assessments was done at baseline, and then every 2 months for the first year, and then every 3 months thereafter until progressive disease. Toxicity assessment and quality of life assessment were done. The statistical analysis was done by a hierarchical model. First, a superiority for progression-free survival was assessed. If it was met, the progression-free survival for 2 was assessed, and then if that was met, overall survival was calculated. So here the in the pre-planned PFS definition of PFS2 in the original 2020 paper, in the original design also had PFS2 which included the duration from the progression from Gefitinib till the onset of the second line of therapy. So in patients with patients on Gefitinib arm, it's a common practice to continue Gefitinib beyond progression. So here the pre-planned PFS2 included the beyond progression duration only in the Gefitinib alone group, which was realized later, and then it was corrected by removing the beyond progressive disease duration. So the corrected PFS2 was analyzed in the update, as well as PFS2 with the same definition. That means the PFS2 including the beyond PD period after the first line, both were calculated in the update analysis. The sample size calculation, the study was carried out over a period of 4 years with 80% power, and 168 patients were required in each arm to show a 5% significance. So baseline patient characteristics, 172 patients in the Gefitinib arm and 170 patients in the combination arm. 2/3 of them were females. Median age was around 64 years. More than 50% of patients were never smokers. ECOG performance status of 0 was in around 60% of patients, mainly all adenocarcinomas, and 22% of patients had CNS metastasis in Gefitinib arm, and around 1/3 had CNS metastasis in the combination arm. 55% and around 55% in both the arms had exon 19 deletion, while rest had the other EGFR mutations. The important thing in the survival analysis in the update was that apart from the Kaplan-Meier analysis, it was also analysis on restricted median survival time. So that RMST was calculated up to 5 and 7 years as a complementary to the log rank test for the overall survival. And the RMST between the combination and the Gefitinib group represented the average gain in the survival within a time window calculated from the 0 to the specified threshold time points, that is 5 and 7 years. And this was on the basis of the area under survival curves for each group. The median follow-up for study was 84 months. So this was the outcomes first reported in the trial. The response rate was 84% versus 67%, and the first reported PFS was 20 versus 11 months. The PFS2, corrected PFS2 was again significant, 20 months in the combination versus 18 months, while the PFS2 with the same definition, including the beyond PD part, was 32 months versus 20 months. The overall survival was 49 months versus 38 months, combination versus Gefitinib arm, though looks like clinically significant with a difference of 11 months, but the p-value was not significant. The hazard ratio was 0.82. Here the subgroup analysis mainly didn't show any difference between the subgroups except difference when it was stratified according to the gender. The RMST analysis, at 5 years there was difference of around 5 months, and at 7 year RMST analysis, the difference in favoring the combination arm was at the tune of around 7 months. Subsequent line of treatment, osimertinib was given in 22% of patients only. Adverse events mainly in the combination arm were myelosuppression, derange LFTs, diarrhea, while Gefitinib, we know that it's involved, it has keen dermatological and GI and hepatic side effects. So this was the first study to evaluate the efficacy and the safety of combination TKI plus chemotherapy versus TKI alone, and it showed that it delayed the development of resistance, higher response rates, improvement in the progression-free survival, and the corrected progression-free survival. However, it did not translate into significant improvement in the OS, though 10-month difference was found. It also had lack of CNS protection in both the arms, and only 22% of patients received osimertinib post progressive disease. No new safety concerns were noted. So it showed improvement in PFS, but not significant statistically significant OS. So we need to see how a combination of osimertinib with chemotherapy turns out. Thank you.